Attention postgraduates, those who are participating for the quiz prelims, please come to the registration desk as soon as possible. Next, we have the short case presentation by Dr. Vrinda CM and Dr. Sharanya VA on the topic pre-eclampsia. The internal examiner is Dr. Venugopal, additional professor at Regional Cancer Center, Trivandrum. The external examiner is Dr. Anju Mariam Jacob, professor at Government Medical College, Trivandrum.
So good morning all. Good morning postgraduates. Ready? So pre-eclampsia is a case that is not only required for your exams, but it is something that we as anesthesiologists will be encountering throughout our lives, whether we are working in a small hospital or in a medical college. And pre-eclampsia along with eclampsia, as you know, is a huge topic. So we'll try to restrict it to a very short, brief discussion touching on some relevant points. So let's go into the presentation. Make sure that your presentation is brief. This is a case which you can diagnose from the history. So keep your presentation and case summary to the history. Okay, so shall we start? Okay.
Please have the case summary.
A 31-year-old primary gravida presented to the labor room at 38 weeks of gestation for safe confinement. On regular antenatal checkup at 24 weeks of gestation, she was diagnosed to be a pre-eclamptic with a BP of 149/94 and 150/92 in 2 consecutive readings with significant proteinuria. She was treated with tab labetalol 100 mg BD and her BP is now well controlled.
Okay, so what is your preliminary diagnosis of this case?
Preliminary diagnosis is 31-year-old primary gravida at 38 weeks of gestation, case of hypertensive disorder of pregnancy, pre-eclampsia, with a single live intrauterine pregnancy in cephalic presentation. She is admitted for safe confinement, falls under ASAPS 2.
Okay, can you classify the hypertensive disorders of pregnancy? Will you classify?
Hypertensive disorders of pregnancy classified into 2, less than 20 weeks and more than or equal to 20 weeks. More than or equal to 20 weeks includes gestational hypertension, pre-eclampsia, eclampsia, chronic hypertension superimposed with pre-eclampsia. And less than 20 weeks, it includes chronic hypertension. Then gestational hypertension means BP more than or equal to 140/90 after 20 weeks of gestation and becomes normal within 12 weeks postpartum. And preeclampsia means gestational hypertension with proteinuria or gestational hypertension with or without proteinuria and one of the features of end organ damage. And eclampsia means preeclampsia with new onset seizures and or coma. In chronic hypertension, there is pre-gestational hypertension and hypertension persists after 12 weeks postpartum. Chronic hypertension superimposed with the preeclampsia means chronic hypertension with new onset proteinuria and worsening hypertension. And preeclampsia can be divided into without severe features and with severe features. Without severe features means mild preeclampsia. Here the BP is more than or equal to 140/90, 2 occasions, 4 hours apart after 20 weeks of gestation. Previously normal BP with proteinuria. Proteinuria means more than or equal to 300 mg per 24-hour urine protein collection. Then urine protein by urine creatinine ratio more than or equal to 0.3 and the urine dipstick 2+. And with severe features, the BP will be more than or equal to 160/110. Then with or without proteinuria and the platelet count less than 1 lakh. And in renal insufficiency, there will be serum creatinine more than 1.1 mg per dl and impaired liver function, severe epigastric pain and right upper quadrant pain, HELP syndrome, pulmonary edema, headache, blurring of vision, scotoma and altered mental status.
And in proteinuria, it can be more than 5 grams. The severe symptoms, with severe symptoms, the mild preeclampsia features, it is only less than 300 or less more than 300 milligram, whereas in severe symptoms, it is more than 5 grams.
So what is this HELP syndrome?
HELP syndrome is a preeclampsia with severe features and hemolysis, elevated liver enzymes and low platelet count.
Okay. Now you had described certain things in the history. as some of them were risk factors. So could you please enumerate the risk factors and what other risk factors will you ask for in the history?
Risk factors can be maternal, pregnancy-related risk factors and partner-related risk factors. In maternal factors, it can be primi gravida, elderly primi, history of chronic hypertension, diabetes or history of GDM, history of CKD, obesity, and history of preeclampsia in family or prior history of preeclampsia in pregnancies. In pregnancy-related factors, multiple gestation, history of molar pregnancy, erythroblastosis fetalis, abruption placenta can be risk factors. And in partner-related, history of limited sperm exposure can be a risk factor.
Hello, can you explain the etiopathogenesis of this condition?
In normal pregnancy, the trophoblastic invasion is complete. That is, the trophoblastic invasion changes the myometrial and decidual segments of the spiral arteries, and thus there will be vessel remodeling. So it will increase the blood flow to the placental unit. But in patient with preeclampsia, this vessel remodeling doesn't happen. There is incomplete trophoblastic invasion. So there will be high resistance vessels which causes a decreased blood flow to the placental unit, causing placental hypoxia. And thereby there can be increased release of anti-angiogenic factors, endothelial cell damage, interstitial leakage, ischemia, and end organ damage. This might cause multi-organ diseases, glomerular dysfunction, proteinuria, brain edema, liver edema, and coagulation abnormalities. So there might be increased production and sensitivity to vasoconstrictors like thromboxane A2, angiotensin 2, serotonin, and endothelin, and decreased production and sensitivity to vasodilators like nitric oxide and prostaglandin I2. The end result is vasospasm, and the triad of derangements include vasospasm, plasma volume contraction, and DIC. Then the pathophysiological changes that occur due to these conditions are airway edema, difficulty in airway management, pulmonary edema, abnormal LFT, and subcapsular hemorrhage. Then fetal growth restriction can occur due to placental ischemia, chances of preterm delivery, abruption. CNS symptoms include headache, visual disturbances, edema, eclampsia, and coma. Then there is vasospasm and plasma volume contraction. The patient will be more sensitive to vasoconstrictor, and there will be increase in systemic vascular resistance. Then the HELP syndrome, thrombocytopenia, proteinuria, and decreased glomerular filtration rate, which might cause renal failure.
So to condense it, there is extensive unopposed vasospasm happening in the uterine as well as in the other vessels of the body, and there is contracted blood volume. There is severe sensitivity to vasoconstrictors. So there is vasospasm happening to all the end organs also, which leads to end organ damage as well. Okay. Next.
So this is what you have to remember when you're looking at the investigations also. Now, we usually have certain physiological changes that occur during normal pregnancy.
Yes.
There are certain physiological changes you've learned that occurs during hypertensive diseases of pregnancy. Now, we don't have to go into the details of that. Just tell me the salient differences between the physiological changes that occur in normal pregnancy versus what occurs in the hypertensive disease of pregnancy.
In normal pregnancy, in cardiovascular system, there will be increase in cardiac output and decrease in the systemic vascular resistance, and blood pressure decreases in mid-pregnancy, which returns to baseline near term. And renal system, there will be increase in the renal blood flow and GFR. Hematology system, there is mild anemia and increase in the clotting tendency. In placental perfusion, there will be adequate spiral artery remodeling. Endothelial function, normal vasodilatation response. And in hepatic system, it will be typically normal. And respiratory system, there will be increase in the tidal volume and mild respiratory alkalosis. But in patient with preeclampsia, there will be increase in the systemic vascular resistance and decrease or abnormal cardiac output. And the BP will be increased more than 140/90 after 20 weeks of gestation. And in renal system, there will be decrease in the GFR and proteinuria, and there will be thrombocytopenia, increase in the clotting factors, and the risk of DIC. Then poor trophoblastic invasion, and which leads to decrease in the placental perfusion, and the endothelial function function will be gets impaired, and the endothelial dysfunction occurs, and it increases the vasoconstrictor sensitivity. Then in hepatic system there will be elevated LFT, and there is a risk of HELP syndrome. And in respiratory system there will be the risk of pulmonary edema in severe cases.
In respiratory system, there is a greater ventilation perfusion mismatch that occurs due to the greater shunting that occurs.
Right.
That is also one difference.
Okay.
Now coming to the investigations which I had asked you to enumerate. Now can you tell me what specific investigations you will do and for what reason you are going to do those specific investigations?
Okay. Over and above the routine investigations including blood grouping and cross-matching, urine protein, RFT, LFT, peripheral smear, platelet count and coagulation profile to rule out end organ damage and severe preeclampsia.
Now, the patient will be on multiple drugs that the patient is on because of hypertension. That is something that you have to keep in mind. Now, can you just enumerate what those drugs are that we usually our patients usually take in the hospital?
And the anesthetic implication also. What are the problems of those drugs?
Okay. So the commonly given drugs in our institution will be oral labetalol or oral nifedipine. Oral labetalol, it is a non-selective alpha-beta blocker, and the main problem associated with it is it causes hypoglycemia, and it is usually avoided in patients with history of asthma, heart failure, heart block, and it might cause bradycardia also. Then oral nifedipine, it is a calcium channel blocker. It can be given at a dose of 10 mg every 20 minutes up to a maximum of 50 mg in hypertensive crisis. And the most common side effect is overshoot hypotension. Other drugs include IV labetalol we can give if there is hypertensive crisis, 20 mg IV followed by 8 mg every 10 minutes. The main side effects are neonatal bradycardia and hypoglycemia, but we use it in uncontrolled hypertension. Then methyl dopa, which is a alpha-2 agonist, its onset is 12 to 24 hours, and it can be given at a dose of 0.25 to 5 mg BD. Main side effects are dry mouth, sedation, and depression. Then if there is any signs of eclampsia or severe preeclampsia with impending signs of eclampsia like headache, blurring of vision, epigastric pain, we go for magnesium sulfate therapy. It can be given as in two regimens. Pritchard's regimen, we give a loading dose of magnesium sulfate 10 gram IM followed by a maintenance dose of 5 gram IM every 4 hours. In Sussman's regimen, we give an IV dose that is 6 gram IV over 15 to 20 minutes followed by a maintenance dose of 2 gram IV per hour, and we have to watch for urine output, knee jerk and respiratory rate.
And what is actually, which all patients you start magnesium therapy? For all patients you start magnesium therapy, or?
And if there is any signs of eclampsia, then severe preeclampsia with severe features.
Symptoms, severe features, and in eclampsia, impending eclampsia. Those with signs of warning signs of impending eclampsia and with history of eclampsia, seizures. We start to go, they will be on magnesium therapy. Is there any role for corticosteroid therapy in preeclampsia?
Yes, sir. In preeclampsia, corticosteroids might help to decrease the improvement in platelet count in HELP syndrome. It has found to increase the platelet count, and also for neonatal lung maturity. In normal pregnancy also we can use corticosteroids.
What is a drug and how much you agree?
Usually for improving platelet count we can use dexamethasone, then
Lung maturity,
betamethasone.
betamethasone for lung maturity, okay.
Now this patient is a preeclamptic patient. She has come for safe confinement. What all presentations then can a patient come to you for as an anesthesiologist? Labor analgesia, what else? How else can this patient present to you?
As an emergency with throwing up seizures, or with preeclampsia with severe features, reduced fetal movements, it can come as an emergency delivery.
Or also it can come for an elective cesarean
Elective
section.
cesarean.
So it's a labor analgesia, can come for labor analgesia, can come for elective cesarean
Elective
section,
cesarean.
or can present to you in an emergency, or they can call you when the patient is throwing seizures in the labor room for a help. Or even at the if it is severe, even when the patient goes in for cardiac arrest. Now, in case this patient is patient has come for safe confinement, she is a primey. She wants to have labor analgesia given to her. Now, how are you going to counsel this patient regarding labor analgesia?
Counseling, it should be carried out in a calm, quiet environment along with patient's husband. And after relevant introduction and building a good rapport with patient, give them options of labor analgesia available in our institution and tell them the advantage and disadvantage of each procedure so that they may be judicially choose their procedure. And it should also counsel regarding the CNS features of last and other complications.
Now this patient you're planning to, you have to tell them what all modalities of labor analgesia that you have, which the patient can adopt, as well as the advantages as well as the disadvantages of this. So most of the time it is epidural analgesia that we are advocating in most of our institutions. Now, you would have told them about all those things. Now, this patient is coming to you preoperatively. It is it is an elective procedure, a planned procedure. Will you keep NPO? What other preoperative advice and will you give to this patient before administering labor analgesia?
Okay. It is important to ensure that hypertension is well controlled, seizure prophylaxis is initiated, and volume status is optimized. Complete physical examination including proper airway evaluation and the equipment to manage a difficult airway, confirm NPO, anti-aspiration prophylaxis, and secure 2 large wide bore IV lines, and blood and blood products must be cross-matched. Radial artery catheter for beat-to-beat monitoring, specifically in acute hypertensive crisis, patient receiving potent vasodilators or CCBs, and in morbidly obese patients. Laboratory investigations include CBC, HB levels, platelet count, LFT, serum, blood urea nitrogen, and creatinine and urine analysis, and estimation of PT-INR, APTT, fibrinogen levels also maintained.
Just go through what all drugs you can give, just briefly, very briefly.
Drugs commonly given include local anesthetics, include bupivacaine, ropivacaine, levobupivacaine or lignocaine. The epidural analgesia we can give 0.0625% to 0.125% of bupivacaine. The adjuncts used like fentanyl, sufentanil for both epidural and spinal analgesia. Morphine and meperidine can be given for spinal analgesia.
How will you find the epidural space?
After placing the epidural catheter in the lumbar region L1, L2, we can give either 10 ml of 0.125% bupivacaine mixed with fentanyl, or we can use 0.2% plain ropivacaine, followed by the same mixture as an epidural infusion at 10 to 12 ml per hour. Then,
how will you find the epidural space in this patient?
For usual normal adults, the epidural space pressure is negative, but in pregnancy, because of the lumbar lordosis and engorgement of the epidural veins, the epidural space pressure might increase. So usually we don't use hanging drop method. We go for LOR, loss of resistance method.
So what are the segments that you want to block with labor analgesia?
In first stage of labor, the dermatomes to be blocked are T10 to L1, and in second stage, dermatomes to be blocked are S2, S3, S4. Then epidural catheter to be placed in mostly L1, L2 or L2, L3, because we need to block T10 segments all the way to T4.
So what are the precautions that you'll take when you're giving a top-up?
So whenever we give a top-up, we have to give the test dose and find whether it has displaced into the intravascular or intrathecal compartment. And also we have to avoid adrenaline test dose in preeclamptic patients.
Now, this patient develops, you're giving labor analgesia, patient develops fetal distress, and your labor analgesia was patchy. This patient is rushed into the OT, labor epidural is there. How are you going to manage this case?
Whenever the epidural is patchy, we go for GA, and over general anesthesia, intraoperative analgesia can be given using NSAIDs, opioids or paracetamol. Firstly, we have to administer 100% oxygen to elevate the fetal distress. Then anti-aspiration prophylaxis, we have to go for rapid sequence induction, and usually it will be a difficult airway, we have to keep it ready and go for rapid sequence induction.
Can you explain the concerns in general anesthesia in this patient?
A patient will be already in a poorly controlled hypertensive status, difficult IV access, the increased response, hypertensive response to laryngoscopy, chances of raised ICP, airway edema, tongue bite or bleeding. If the patient has any eclamptic features, then thrombocytopenia, coagulopathy. Already the patient has plasma volume contraction, high risk of pulmonary edema, end-organ dysfunctions, and also if the patient is on magnesium sulfate, it has got drug interactions with the muscle relaxants that we use.
So what is the post-operative analgesia plan? How will you plan for that post-op analgesia?
If the epidural catheter is working well, then 0.2% ropin can be used as an epidural infusion for up to maximum of 72 hours. Then oral add-on drugs, paracetamol or NSAIDs, 6 to 8 hourly IV or oral paracetamol 1 gram commencing 6 to 8 hours after the intraoperative dose, and 6 hourly oral ibuprofen 400 to 600 mg unless contraindicated commencing 6 to 8 hours after the dose of intraoperative diclofenac or ketorolac. Then patient controlled epidural analgesia with or without the rescue block, that is tab block, can be given. In the presence of long-acting neuraxial opioids, as OP recommends, the patient should be monitored ventilatory frequency and sedation 2 hourly for 12 hours.
Now, in the labor room, while you are giving top-up, patient suddenly throws a seizure. What are your differential diagnoses?
It can be eclampsia, local anesthetic systemic toxicity.
What else? Hypoglycemia.
Hypoglycemia.
Can be electrolyte imbalance also. How will you manage the case?
If it is due to eclampsia, we can first line magnesium sulfate we can use.
Whenever there is a seizure, you have to think of the ABC first. Okay. Then only going for that.
Okay, madam. Secure the airway, then proper positioning of the patient. There will be more chances of tongue bite. Ensure proper padding of the patient. Secure.
What drug will you give for the seizure?
Lorazepam, phenytoin, thiopentone if it is easily
If
available.
you are in the OT or if it is available and there's an anesthesiologist nearby, that's an old drug that is being given. Now, the patient, you have treated the seizure, but you were unsuccessful, saturation fell. Patient goes into arrest. How will you manage?
The patient goes into arrest, we have to start with the ACLS protocol. So high quality CPR, defibrillation if indicated, and other ACLS interventions including adrenaline. And we have to assemble the maternal cardiac arrest team as soon as possible and consider the etiology of the arrest. Then we have to provide certain maternal maneuvers and obstetric interventions, perform airway management, provide 100% oxygenation and avoid excessive ventilation, and also place an IV cannula above the level of diaphragm. And if the patient is receiving IV magnesium, we have to stop that and give calcium gluconate or calcium chloride. And also we have to provide left lateral displacement of the uterus and detach all the fetal monitors and prepare for a perimortem cesarean delivery. If no ROSC is achieved in 5 minutes, consider immediate perimortem cesarean delivery.
So in this patient, which will you prefer, regional or GA? Why? Last question.
We can, if there is no coagulation abnormalities or absolute
In this case, you presented
contraindication,
no, there is no coagulation abnormality. Patient is otherwise
We can
fit
go
patient. The
for,
only thing is hypertension with proteinuria. So which will you advise and why you want to go for that?
regional anesthesia.
Why?
Sir. Because in GA there are more problems associated with hypertensive crisis due to intubation.
So you listed the concerns in GA, but I want to know what are the advantages of regional. You are opting for regional, so tell me the advantages of regional.
Regional, we can post-operatively also we can provide good analgesia if there is an epidural catheter.
So the like airway instrumentation is not
the
there,
problems
stress response
associated,
is not
stress
there.
response is
So
not there.
early ambulation is possible. So all the advantages of regional are you can use here. And the only thing is the concern is our platelet count, but this patient is having a normal platelet, so there is not much of concern in that. So thank you. I think you answered almost well all the questions. So
Yeah, you've done well. Most of the questions you've answered. Congratulations.
So both of us thank the entire team of ISA Midcon, Mopens Medical College, Wayanad, and ISA Kerala, Wayanad City Branch for allowing this for opportunity for us. Thank you.
Thank you very much.
Thank you, doctors. Now, I request Dr. Anju to kindly distribute the certificate of participation to Dr. Vrinda and Dr. Sharanya. Now, may I request Dr. Aruna to please come onto the stage to felicitate Dr. Venugopal. I also request Dr. Suvarna to please come onto the stage to felicitate Dr. Anju.